Hello, everyone. Good evening, and welcome to the second installment of our new subscription series, Science on Film. My name is Teresa Scandifio, and I'm Senior Manager of Adult Learning here at TIFF Bell Lightbox. We're delighted that you're here to join us for what promises to be an engaging and innovative series that uses film as a springboard for discussions at the intersection of popular science, art, culture, and technology. So before we start, I'd actually like to take a moment to say some thank yous to the folks who made this program and this building possible. TIFF would like to thank our lead sponsor, Bell, major sponsor, RBC, and our major public supporters, the Government of Canada, the Government of Ontario, and the City of Toronto. We'd also like to thank our Science on Film partner, Penguin Books. So yeah, woo, books, Penguin, all good. So a reminder of what is up to come. There are 4 more exciting films and conversations to look forward to as part of our Wednesday evening series. Distinguished Professor Elizabeth Loftus on workings of memory in Eternal Sunshine of the Spotless Mind, science fiction author Robert J. Sawyer on The Day the Earth Stood Still, sexuality researcher and scholar Dr. Robin Milhausen on body heat, and you're like, no response. An Academy Award-nominated makeup artist, Adrienne Moreau, detailing the aging effects in Barney's version. Single tickets are now on sale for each upcoming Science on Film event, and information on how to purchase them is available at the box office as well as tiff.net. So, what do we have in store for you tonight? We have a fascinating guest expert here with us, Dr. Martin Antony, Professor and Chair of Psychology at Ryerson University, who will join our incredible host, Jay Ingram, on stage after the screening of Alfred Hitchcock's Vertigo. And, we were just talking about there's so many different aspects of science and psychology that could focus with Vertigo, but here we're going to talk about the intricacies of anxiety disorders and phobias like the ones exhibited by Jimmy Stewart's character in this classic film. So we can think of no one better to host our new Science on Film series than the immensely accomplished and award-winning author, public speaker, and TV personality, Jay Ingram. Please join me in welcoming him to the stage.
Hi, everybody. I was going to mention all the films that are going to come after tonight, but Teresa did that. And then I was going to introduce the special guest, Martin Antony. Teresa did that too, very well. So what do I have left to say? As she said, one can look at any Hitchcock film and take diametrically opposed views of what was going on, what he was trying to say, what the symbolism was. And the same is true of Vertigo. So I heartily recommend you pay very close attention to it because we're going to be able to tease out with Dr. Antony some things that probably you wouldn't come across in the sort of traditional film literature. So that's going to be pretty cool. The other thing is that we really feel strongly that even though he and I are going to kick off the conversation, the point is to have you part of the conversation as well. So we have mics for questions at the end, and for technical reasons, we really, when we get to that point, and you're bursting with questions, you're going to have to be just a tiny bit patient to allow the mic to get to you so that we can record it all at a more or less equal level. So that's it. I'm looking forward to the film, and I think the discussion's going to be great too. So I don't know, what do you say before a film? Get comfortable and we'll watch Vertigo. Next time we're going to have the talk before the movie. So I think he had a lot more problems in Vertigo, but before we get into them, it's really fortunate that we have Marty Antony with us. He's chair of the Department of Psychology at Ryerson. What a perfect movie to have a chair of the Department of Psychology. He also is director of research at the Anxiety Treatment and Research Center at St. Joseph's Healthcare in Hamilton, Ontario, and has a long list of accomplishments, which if you're interested, I'll leave this up here and you can come and read it a little bit later. I have many questions, but let's start with your reaction to the movie.
I thought it was great. I'd never seen it before. I saw it a couple of days ago for the first time, and I thought it I'm kind of coming at this from the perspective of someone who does work in the area of phobias and anxiety disorders, and knowing that this was a sort of science on film series, sort of thinking about sort of the accuracy of the depiction of the kind of problems that Scotty was having in the film. And I think there are a few things that were noteworthy. So, I mean, one thing for me that kind of stood out, and again, the phobia was actually a pretty small part of the film, so that was the piece for this particular purpose that I was kind of focusing on. And the treatment for the phobia that seemed to kind of come out a little bit in Midge's apartment at the beginning and then at the end as well, in kind of a weird kind of way, was this sort of knowledge that in order to conquer it, he had to basically confront the fear and do the thing that he was afraid of. Which at the time when this came out was just emerging really. Now it's the standard treatment. There's been lots of studies showing that exposure is really the way to overcome fear, but at the time it was just emerging, that kind of knowledge. And at the time the prevailing therapy would have still been psychoanalysis, which is kind of, you know, the
wouldn't have made as good a movie, though.
No, it wouldn't have made as good a movie. But the in the hospital where he was hospitalized, for example, the psychiatrist or the staff really had no idea what to do with him, which might have been a sort of realistic depiction of the way things might have been in the late 50s. I think the treatment would have looked very different now.
You know, it's I should explain that Martin and I met about 15 or 16 years ago when I was just starting what is now Daily Planet, and we did a story on curing, I think that's the right word, curing a young woman of fear of spiders. And what struck me at the time that was really puzzling was this exposure thing. That you know, well, you're uncomfortable with spiders, so we have one in an aquarium across the room. And I mean, the first time that happened, she was squirming. Then eventually she was actually able to, well, the ultimate was to crawl through bushes without being afraid.
Yeah.
But it puzzled me that it's that straightforward, that you can do that.
Yeah, absolutely. With especially with something like an animal phobia or a height phobia, it's usually treatable within hours. So the person who we treated 15 years ago was about 3 hours of exposure. She went from initially the point where she couldn't be in the room with a spider to the point where it was crawling all over her comfortably. And for a lot of people, it's just, in fact, one of the things she said in the video, I use the video for teaching quite a bit, so I actually have it over the last 15 years of watching it over and over and over again. A lot of the lines have kind of burned into my brain, but one of the things she says at the end when the spider's crawling all over her is that if you had told me I'd be able to do this at the beginning, I would have thought you were crazy. People are often shocked at how quickly they can make changes with exposure. And it's not just with people. We see the same thing. I mean, a lot of the early studies with exposure were done with animals, just showing very quickly how animals can overcome fear just through practice.
And does that apply to all phobias?
Certainly for things like animal phobias and needle phobias and height phobias, some of the more complex kinds of fears that people have, so the kind of fear that we see in social anxiety, you know, sort of severe shyness or obsessive-compulsive disorder or post-traumatic stress, the more complex kinds of problems, exposure may not be enough, and there may be lots of different stimuli that people need to be exposed to, and you may not see the same complete recovery, and definitely not as quickly as you would with an animal phobia, for example.
Now, they also, so wait a minute. So that at one point, Midge said, you're going to have another severe, extreme emotional experience to cure yourself of that. So was she kind of voicing what was thought at the time?
I'm not sure. It seemed like an unusual thing to say to me, for me to hear anyway, because normally when people are exposed to multiple traumas, you don't see after the second trauma that the problem goes away. If anything, you see a worsening of the problem that people are having with repeated traumas. You know, one of the things I was kind of the second time I watched it, which was tonight, I was sort of reinterpreting a little bit what had happened at the end. And one of the things I wondered about is he looked down at the end and he wasn't afraid anymore. And one of the things I wondered is whether he was reattributing symptoms that normally he would experience when he's afraid of, but attributing to anger, and possibly just reattributing or interpreting those symptoms in a different way was less frightening for him. That's something that we see in people frequently, is that how they interpret their symptoms in a situation can have a big effect on the emotional experience that they have.
You mean I'm feeling this way because?
Yeah. So just to give you a quick example, I was working with a client who had a agoraphobia and had a lot of fear of experiencing panic attacks and uncomfortable physical feelings in public places. So racing heart, dizziness, and perceptual changes, and sweating, and breathlessness. And she had an experience where she was in a theater, and she started to get one of her usual panic attacks, and she was feeling dizzy and getting anxious. And at that moment, her husband turned to her and said, "Aren't the lights in here strange?" And as soon as he said that, her fear went away. She knew that the physical feeling she was experiencing probably or maybe had something to do with the lights and not the fact that she was maybe having a heart attack or something.
And she was able to carry that on to other situations?
Yeah, she came in the next week. Well, for that particular situation, yeah, it didn't make the problem go away, but in that moment anyway, it made her fear go away.
So again, when he went up the 2 or 3 steps of the little kitchen ladder, that would have worked, maybe, ultimately.
Well, he stopped too quickly. Yeah, so I would have encouraged him when
if you'd been on the set.
If I would have been on the set, I would have encouraged him to try to get back on. Maybe not go right up to the top step initially. Maybe go back to that second step and kind of work his way up. It wasn't sort of a typical specific phobia of heights in that he clearly had a trauma. So most height phobias, some do begin with a trauma, but a lot of them don't. But he also had these flashbacks, dreams and sort of flashbacks to the event, which is more common in sort of a post-traumatic stress kind of reaction than a real simple, specific phobia of heights.
Well, he seemed to have a real grab bag of psychological issues because they described it, as acute melancholia and guilt complex. Now, are those words that psychologists would use now?
Now, absolutely not. So when the film came out, which was 1958, the Diagnostic and Statistical Manual for Mental Disorders, which is the book that the American Psychiatric Association publishes that defines the different characteristics of different psychological problems, we're now on the 4th edition. The first edition, I believe, came out that year or right around that year. And in those days, certainly people would have used those kinds of terms. Melancholia nowadays would be called depression. And certainly guilt would be a feature of that. But we wouldn't use that term anymore.
It wasn't clear in the movie why he went from being mute in that hospital to searching for whatever he was searching for, her, I guess.
Yeah.
Do you have any thoughts on that? I mean, I know I'm kind of asking you to speculate about something that wasn't even there.
Right. Yeah. Normally, I'd want to do I'd want to ask the patient some questions.
Happy to do that.
Normally I'd want to do some sort of full assessment, but in terms of just speculating, the sort of muteness, I was sort of thinking about that, and at that time, with psychotic disorders like schizophrenia, you would see sort of a catatonic kind of state sometimes, and the medications that we have now that might have treated that kind of state might not have been available at that time. It's possible, and sometimes in depression you can see the kind of hallucinations and delusions and other kinds of psychotic symptoms that you might see in schizophrenia. So it may have been a catatonic state where somebody would have been non-responsive like that and they just wouldn't have had appropriate treatments. The other possibility, though, is I was looking at his face in the movie, and although he wasn't saying anything, he was responsive. So he was sort of attending to things that she was saying. He would look up. The look on his face suggested that he was upset. He was thinking about things, but wasn't communicating. So it's hard to know. I mean, I don't know why he was doing that, and I certainly don't know why a month later he was, or whatever period that was, he was. I don't know what obviously what happened between those periods.
So, but when you look at how he was through the whole movie, where he went through first demonstrated the vertigo, and then these symptoms, and then the absolute obsession with changing her. Does this just sound like too many things for one individual to have?
Well, one thing I can say again, I was coming at this really from the perspective of thinking that I'd have to be thinking about the height phobia, which was the least of his problems in this movie. It's not unusual for people to have multiple issues that they're dealing with. So if somebody is dealing with depression, we know that they're more susceptible to having anxiety problems. If they have post-traumatic stress problems, they're more susceptible to having depression and other anxiety problems. So it's not unusual for people to have multiple kinds of issues. I'm not sure, what was happening at the end. I was asking myself, why is he doing that? Is he wanting to turn Judy into Madeline? Is he still convinced that maybe it is Madeline? He wants to see her dressed as Madeline so he can kind of see what that is. I mean, I have no idea. But again, if this was somebody I was working with, I would have a lot of questions, and I'd want to be very careful about speculating or assuming anything until I had a lot more information.
I just want to ask a couple of questions about your sort of daily work, and then I think we'll get to questions from all of you. Is vertigo, well, first of all, is it even called vertigo anymore?
Vertigo is more the physical sensation of the sort of spinning or dizziness, and it can be a feature of fear of heights. It can be a feature of all kinds of things. People can have an inner ear problem that creates that sensation, but we do see people who have a fear of heights who will experience sort of a dizziness, lightheadedness feeling when they're in high places.
So how common is it? How many patients would you, when you were seeing patients all the time, how many would you see with that? With fear of heights?
It's a very common fear. So of the specific phobias, which includes height fears and animal fears and blood and needles and driving fears and flying fears, it's the second most common overall after animal fears, animal phobias. And for men, it's actually a little bit more common than animal phobias. For women, it's number 2. For men, it's number 1. And then overall, it's number 2. So about 5% of the population. What's interesting is people with specific phobias, though, rarely show up for treatment. So I've seen a few people with height phobias over the years, maybe 10 or something like that. So even though it's one of the most common problems that people have, they're able to live with it, as he did in the movie. I mean, the height phobia, again, was not the thing that caused some problems for him. Some of the other difficulties that people have, like extreme social anxiety or panic disorder, obsessive compulsive disorder, some of the other anxiety problems are much more impairing and more likely to bring people into treatment, even though they're less common overall.
Some of them seem to make a kind of sense. If you have a phobia about snakes or spiders, well, it's pretty easy to see why that actually might have been a smart thing, tens of thousands of years ago. But others are not so. Is it understood how phobias develop out of what might be normal reactions to things?
Yeah, so if you look at the situations that people fear, they're not non-random. They're not random. That people tend to fear heights and animals and things that could break their skin, like needles or seeing blood. And so we call these prepared fears. So that the thinking is that somehow we are hardwired to learn to fear some things more easily than others. So you can, it's much more easy, for example, to learn to fear dogs if you're bitten by a dog than it is to learn to fear flowers if you're pricked by a rose or something like that. There's something about the way we're wired that makes it easier to learn to fear snakes, for example, than electrical sockets, which are, can be potentially very dangerous, but probably, well, we know were not around prehistorically, so we wouldn't have evolved to have a fear necessarily of electrical sockets.
And do you ever see phobias that surprise you because they are something that you wouldn't expect a phobia to develop out of?
All the time, yeah. So people often ask me, is it, when they have an unusual fear, is this, have you ever seen this before? Is this unusual? And my answer is usually, when that's the case, that yes, this particular fear is unusual, but it's not unusual to have an unusual fear. So I remember one person that we saw who had a fear of airplanes flying overhead. She was perfectly fine if she was in the airplane. But if she was on the ground and the plane was flying overhead, she would panic. And there were all these things that she had to do. So, for example, she'd hold if she was holding an umbrella, she'd feel comfortable. And we were trying to figure out what it was about that. I thought maybe she was afraid that the toilet would flush on the airplane and it would land on her. Something. Yeah, but it wasn't that. She had no idea what the fear was, but if she had an umbrella open, she wasn't afraid of the plane flying overhead. Seen people who are afraid of cotton balls and Q-tips and things like that. When I say people, I mean a person. Both of those are individual people. They're not fears that you'd see very often. And we did, when I was working at the Clark Institute, which is now the Center for Addiction and Mental Health, there have been lots of studies showing that it's very, very difficult to condition a fear of flowers. I mentioned that it's much easier to fear dogs than to fear flowers. Within 6 months, we had 2 patients come to the clinic who were afraid of flowers. In one case, it was sunflowers, and had an experience when she was about 3 years old where she was in a sunflower field and she got lost and couldn't find her parents. And from that day on, she would panic whenever she saw sunflowers. And the other person, it was hollyhocks, and it came from a childhood situation where this man was chased by his sister with hollyhocks and developed this fear of hollyhocks. So, and I've never seen or heard of another flower phobia before that or after.
And would it in those cases would it be able to cure that by exposure?
Absolutely. There have been studies looking at whether about half of people with phobias report some sort of traumatic onset. For other people, they don't know how it began. And it doesn't seem to make a difference in terms of treatment outcome for a specific phobia like that, that whether it has a traumatic onset or not, the treatment seems to work just as well.
It's totally fascinating stuff, but I think that we should throw it open to questions from the audience. So just a reminder, if you have a question, just hold up your hand, please, and a microphone bearer will find you. Or if you, I was going to say, or if there are no questions, we'll just keep going.
Hi. I noticed there was an awful lot of alcohol consumed in this film.
Mm-hmm.
And I think some of it was just 1950s American culture, but I know that now there is this notion of self-medicating. And I'm just wondering, with something like a phobia or other mental disorders, does the notion of self-medicating with alcohol help in any way, or does it actually make the situation worse, or is that an individual thing?
Yeah, it depends what you mean by help. So certainly in the moment, alcohol helps. So we know that alcohol acts on the same neurotransmitters in the brain as anxiolytics, like alprazolam, like Xanax and Valium. It acts on GABA, which is a neurotransmitter that underlies anxiety. So there's no question that alcohol makes people feel more comfortable, and I think people figure that out and may start to drink more heavily. You don't see a lot of excess alcohol use in a specific phobia typically. So if someone's just afraid of heights or just afraid of spiders, they deal with it mostly by avoiding rather than drinking. The only exception might be flying phobias. I've certainly seen people that have to fly and will have a few drinks on the plane. Where you do see a higher rate of excess alcohol use is in some of the more complex anxiety disorders that you can't really get away from as easily as you can with a height phobia or a snake phobia. You just stay away and you don't have a problem. With something like social anxiety, extreme social anxiety, where pretty much every situation is a social situation. Even when you're driving, other drivers are judging you and calling you names and honking at you. And for people who have more chronic anxiety in a lot of different situations, we're more likely to see problems with excess drinking than we would in people who don't have anxiety problems.
If you watch any episode of Mad Men, yeah, they're all self-medicating quite heavily.
Yeah, over here on the, you're right.
Oh, yeah.
Yeah, one thing Jimmy Stewart witnessed in the movie was suicide. Could you talk about the potential trauma on somebody who witnesses that and potential treatments for that?
Yeah, so people respond to trauma in lots of different ways. For a lot of people, initially following a trauma, they would have a lot of the same kinds of symptoms that you would hear about in post-traumatic stress disorder. They might have flashbacks or dreams about the trauma. They might have difficulty sleeping. They might find themselves having trouble concentrating, more problems with irritability, problems with hypervigilance where they're looking over their shoulder for possible threat. A lot of avoidance of situations that remind them of the trauma. So it'd be perfectly normal for a few days following a trauma to have those experiences. For some people, they would go on to continue to have those experiences and might, if it goes on for a month or more, have develop sort of a post-traumatic stress kind of reaction. A lot of people, they might not have full-blown PTSD, but might have symptoms of that. But trauma or stress like that is really a risk factor for just about every problem that people can have. If people are prone to drinking, they might start drinking too much and have that kind of reaction. Or if they're prone to depression, that kind of experience might trigger more of a depressive episode. So these kind of or either acute stresses like a suicide or something, or chronic stress, really increases the risk for any kind of problem, I guess, potentially, even physical problems. We know that stress can lead to heart disease over long periods. So whatever people's vulnerability potentially is where you see the effects of the stress often.
And if you do develop something like post-traumatic stress syndrome as a result of seeing something shocking like a suicide, is that reasonably well treated today?
Yeah, there are a number of different approaches to treating post-traumatic stress. Cognitive strategies, teaching people to look at some of the thoughts that they have that contribute to that response. So people may themselves feel that they're to blame for the trauma, for example, or they may have the belief that if they had just done something differently, they could have prevented it. They may have an exaggerated belief that they're at risk for experiencing the trauma again, even though they're not. So teaching people strategies for looking at those beliefs and looking at other ways of looking at the situation is one strategy. Some relaxation-based strategies, teaching people to relax physically can be a useful strategy, and exposure as well. So if people have been in a car accident and they avoid all driving, we know that gradually encouraging them to begin to drive again can have a big effect on reducing fear. And sometimes people with post-traumatic stress also will start to avoid memories of the trauma. And we know that the more you try to suppress unwanted thoughts, the more they come back, and the more distressing they are when they come back. So teaching people to allow those thoughts to happen rather than constantly pushing those thoughts away can be useful as well.
I'm really glad you said that, because there was a recent issue of Scientific American in which it was claimed if you have unpleasant memories, you can repress them and they will disappear. And I thought, this is like, trying not to think of pink elephants.
Exactly, yeah.
And I was skeptical, and then of course all my friends read it and said, "Oh yeah, I can do that."
I do it with audiences all the time. I'll ask people. I use a white elephant, but same basic idea. I'll ask audiences if I'm giving a workshop or something to try to not think about a white elephant for 30 seconds or something like that, and I'll ask them then how many people were able to do that, and very few people are able to do that. But now, over the last 10, 15 years, there have now been dozens of studies showing that you get a rebound effect. So in the period immediately following the suppression, if it's an unwanted thought,
There's white elephants everywhere.
Yeah, it either comes back, in some studies show it comes back more frequently, so you actually get an increase in frequency. Some studies don't show that, so there's some inconsistencies. But one more consistent finding is that you see an increase in the distress associated with those thoughts. And we used to do that all the time when we treated obsessive compulsive disorder. We used a strategy called thought stopping, where if somebody got this intrusive thought about wanting to harm someone else, even though they would never act on it, they were taught to stop the thought by just saying stop, and pushing the thought out of their heads and flicking a little rubber band on their wrist to distract themselves. And we now know that that doesn't work. If anything, it makes it worse. So we encourage people to bring on the thoughts, let it happen until they're not afraid of the thoughts anymore, and then the thoughts don't happen as frequently.
Yeah, over here.
Oh, sorry, yep.
Oh, sure. I just wanted to ask if you would speculate on Alfred Hitchcock. Do you feel he was normal? And how is it that he was able to create mass phobias like birds and all that kind of stuff?
I have no idea. I was watching a little bit on YouTube just in preparation for this a few days ago, and watched a couple of interviews with him because I was wondering what he was like. And one of the things he talked about he gets asked all the time if he likes to be scared, for example, and he said no. And basically, I mean, the way he came across is just sort of an interesting guy with an interesting kind of twisted sense of humor, but didn't seem, at least in that interview, there's nothing I saw that made me speculate about what might be going on in his mind. And again, as a more of a behavioral psychologist, I try to be careful not to speculate too much without some data. So again, there's a whole bunch of questions I'd want to ask him if I had that that opportunity to kind of figure out what was going on.
Widely believed that he was obsessed with blondes. And this movie wouldn't change your mind about that. I think up here.
So thinking about the film in terms of stigmatization of mental illness, or specifically panic attacks or anxiety disorders, I felt like he was, there was this underlying theme of guilt and it being his fault that he had this, and he was very emasculated, especially in that scene in the courthouse where they were really laying a lot of weakness on him. And then he kind of took it over the top towards the end with the facing it, and kind of became a bit of a psycho in terms of his anger, and but we're still rooting for him. How does how is it resolved nowadays in culture, seeing as it is with panic disorder, we are supposed to turn to face the fear. So there is an element of personal responsibility in terms of that, and how does that play out with stigmatization and stuff like that now, if that's clear?
Yeah, I think now there's so many different approaches to understanding problems that some approaches in psychology and in psychotherapy might still, I don't want to use the word blame, but might still see the problem as something sort of within him. From a behavioral perspective, there's certainly something that the person brings to the situation, but a lot of, when I look at this, a lot of what he's doing, I guess, in the film could be seen as a reaction to this environment that he's in and these experiences that he's had that are really experiences that almost that people just generally don't have, and none of us know how we would respond in that particular situation. So again, at the end, it gets kind of weird, but again, there's that. At the end, there's the intense anger that goes along with the love that he had for her and the betrayal and all the other kind of complicated things. And I don't know exactly how to understand what happened at the end. Stigma is still a problem, and in this film, mental illness was depicted in a particular way. In more modern films, it's depicted in other ways that are still inaccurate and still, I think, put out misinformation about mental illness, and not just about mental illness, but also the process of treating it. So when I find it very difficult sometimes to watch movies that have psychologists in them or therapists watching what they're doing, because it also, I think, sends the wrong message about what a psychologist would be doing in a situation and what's appropriate sometimes. I'm thinking there's one film that just so many examples. One that I always remember is Nell with Jodie Foster, and Liam Neeson was her therapist, and there was I can't remember what problem she had, but I think she was nonverbal. It may have been autism or something like that, and she had been for treatment with lots of different people, and nobody could reach her. And then finally she met this guy, Liam Neeson, who became sort of obsessed with her case, and it seems like he just dropped all of his other cases and just all of his focus was on her, and he was doing all these sort of non-conventional things. In one scene, they were skinny dipping together in a lake, and again, this is her psychologist, and it's all presented as this beautiful thing, like if other psychologists would just do these non-conventional things, then by the end she's talking and everything's great. And that's just, I'm cringing thinking that this is the message that this movie is giving, that psychologists should be swimming naked with their patients, and so anyway, I think that hasn't gone away, that kind of misinformation, and I think that does contribute to stigma.
You sure couldn't argue the psychologist in the movie didn't have things well in hand. I don't know how long he's going to be here. Oh, that's bad that he's in love with her.
That's probably a more realistic depiction,
much worse.
actually.
I have a golf tournament I have to get to.
Yeah.
How plausible was the supposed delusion that Madeline was suffering from, that she was kind of reenacting the life of her great-grandmother Carlotta, and that was kind of the setup that Jimmy Stewart fell for and kind of we all fell for?
Yeah, so the question is could you see something like that in real life, I guess? Yeah. I guess with delusions, you can see just about anything. So by definition, a delusion is something that somebody believes firmly, 100%, despite the fact that all of the evidence says something different. So people may believe that aliens are controlling their mind. They may believe that they're Jesus or Napoleon or something like that. So I mean, delusions can really take just about any kind of form in terms of the content. The content is often related to things in somebody's life, I guess. So if somebody is very, very religious, for example, and they also have schizophrenia or develop some sort of delusional problem, the delusions may take on a religious kind of content potentially. So I haven't seen that particular kind of story, but if I did, it wouldn't shock me, I guess. Yeah.
Can I talk? Okay. Hi. I was wondering. I feel like in the movie a lot of what was sort of depicted as love almost felt like a need,
Oh, yes.
or like that love really was like something that Jimmy Stewart's character really needed in that sort of time of trauma, and the same thing for I guess Kim Novak and her sort of weird, like, trying to kill this woman but not really wanting to kill this woman. And I was just wondering if you could speak a bit to sort of how often that happens sort of in real life, that love becomes sort of something that somebody with an anxiety disorder really needs. And yeah, how much have you seen that, I guess, is the question.
I can speak. I'm going to kind of talk around your question a little bit, I guess. I think a couple of things. So one is, I think when people have intense anxiety or intense depression, they will seek out support from other people. So if somebody is very, very anxious or upset, it's not unusual to want that kind of support from others. And sometimes it's done in a very healthy coping kind of way, and sometimes it's excessive and may be experienced as neediness, and may actually lead to the opposite response from people. If somebody's putting too much pressure on somebody to give that kind of support, people may feel smothered by that, and it may have the opposite kind of effect. So that's one thing. Another thing that struck me about that kind of love that seemed to just come out of nowhere. I mean, she jumped in the San Francisco Bay, he saved her, and all of a sudden they were in love. And here I really have no idea what the research says about this, but here I'm being more of a movie critic, I guess, than a scientist. This sort of notion of having this intense emotional experience that you've shared with somebody else might somehow strengthen that kind of bond in that kind of situation, possibly. I'm just making that up, though.
That's why we got you here.
Excellent.
There's a question over here, right?
Hi, this might be more of a sociological than a psychological question, but I just wanted to ask you, it's obvious that Scotty lives in a really, isolated manner. He lives in this drab apartment by himself, and Madeline remarks when she comes to that nobody should live alone. And I was wondering if people who are obviously socially isolated, like Scotty was, who had to retire from the force and doesn't really seem to have many friends other than Barbara Bel Geddes, if they're more prone to kind of fetishizing nostalgia, like with the Carlotta myth and such, if they try to escape from reality in that kind of way.
I have no idea. It's a good question, but I'm not. There's lots of things we know about social isolation, that they increase risk of depression. People who have anxiety problems are more likely to be socially isolated than people who don't have anxiety problems, just statistically speaking. And social isolation also has an impact on people's ability to recover from problems with anxiety and depression. That social support is very important. But whether it leads to the kind of thing that you saw here, I'm not aware of any sort of specific work in that.
But it might make sense that because he did have an anxiety issue, he was somewhat, because you were saying that often pairs up, that he would be so socially isolated.
Yeah, it's possible that the anxiety or the depression he experienced were exacerbated by that social isolation. But you're thinking about that sort of fantasy kind of sort of obsessive kind of behavior that you saw, and whether that's related to social isolation. Possibly. We do see sometimes in families, for example, that are living with somebody who has a drinking problem or has an anxiety problem or depression. The family kind of adapts to the situation, where over time it almost seems normal to them, and it's not until they get away from it that they realize how much of a problem it is sometimes. And I guess an individual as well, if he's isolated, doesn't really have people to kind of do reality checking off of, and that may exacerbate the experiences he's having. Again, I'm just I'm speculating, so psychologists don't like to say anything with any kind of confidence or authority. So I'm being very careful, but.
In the movie, they briefly depicted kind of the idea that Madeline would be more prone to suicide because of hereditary reasons, because of her grandmother. I was just wondering how likely it is to be prone to some sort of disorder or phobia based on genetics and whatnot, and if so, is it likely that that is genuinely hereditary, or could it be trained, such as a mother that has a fear of dogs taking her children away from dogs every time that they pass?
Basically, everything we are has a genetic component. Our personalities do, the way we perform in school, certainly our emotional experiences, whether we're prone to anxiety, whether we're prone to depression, whether we're prone to suicidal behavior, all of that has a genetic component. It's very different than, say, eye color, which is 100% genetically inherited unless you have those fancy contact lenses that change your eye colors. So here it's more of a predisposition that the genetics create. So there's no guarantee that, if you have sort of a family history of suicide, that you will necessarily experience that same kind of suicidal behavior. What it means is that your chances are higher. So if the chances of developing full-blown depression is about 10% of the population or something like that, and you have a genetic history of that in your family, that might increase your chances to 20% or something like that. I'm just throwing these numbers out. Those aren't exact numbers. It's not like it makes it 90%, though. It just increases your chances. And like a lot of things that have a genetic predisposition, they're still very much influenced by experience and by behavior and what you do. So, for example, obesity has a strong genetic component, but in order to gain that weight, you can still control that by eating less or exercising more. What it means is that somebody who has a genetic predisposition to be heavy is going to have to work harder at not being heavy than somebody who has a genetic predisposition to be slim. And it's the same with depression or anxiety. Somebody who has that predisposition may have to work harder to not let those feelings get the best of them. Or they may, if they have that genetic predisposition, following certain stressful life events, they may develop problems with depression and anxiety more easily than someone who doesn't have that predisposition, but you still may need that stressful life event or series of events to trigger it. So it's much more complex than just than eye color or hair color or something like that.
And I think we have one question down here.
Yes, the only person that hasn't really been talked about in the movie is the husband, who seems to have been the catalyst for all this emotional turmoil. And I just wondered, do you ever run across people like that are so manipulative, that know other people's phobias? And
now, this is my mother-in-law, so this might be a trick question. So I'm trying to think. Yes. So, and actually, in some ways, Judy.
Always start the answer to your mother-in-law's question.
The answer is yes. Judy, in some ways, Judy and the husband were actually the more interesting characters in some ways. So these would be sort of classic kind of psychopath, sort of antisocial. Well, Judy was more complicated, but the husband certainly came across as sort of a classic, cold, calculating psychopath who basically felt no guilt or remorse for things that he had done, was very manipulative and very comfortable lying, and a very successful psychopath. Psychopaths aren't always as successful. They tend to get caught a lot because they don't learn from their mistakes. He was a good psychopath, a successful psychopath.
There was actually some distress in the American film industry because it looked like he was successful. And they asked Hitchcock to put in a little piece at the end where I think Barbara Bel Geddes gets a phone call and the guy's been arrested in France. And then Hitchcock refused to tack that on. Up here.
Over there first, I think.
Hi. In the first half of the movie, a lot of it was devoted to this idea that maybe Jimmy Stewart was hallucinating the whole thing, and maybe she wasn't even real, and the idea that she was a ghost. And obviously that was all just manipulation from outside. And that reminded me of another old movie I've seen called Gaslight, where a similar thing was done to somebody, Ingrid Bergman, and it drove her crazy. And it drove, obviously, Jimmy Stewart pretty crazy in this movie, too. I think even gaslighting was a term for doing that to somebody at the time. So I'm just wondering if that's plausible. Are you aware of any real-life situation where somebody's been driven crazy like that by being driven to these delusions that they're not actually having?
Not specifically that kind of response, but people certainly are susceptible to information and can make a sort of enormous sort of changes. Their memories can change based on information that's planted. How many of you are doing this whole series, and we'll be at the next, so a few of you will. So you'll see Elizabeth Loftus speaking in, is it next month? March, I think? Yeah. Speaking about memory. And she's one of the world's leading memory researchers. And she's done all kinds of interesting work showing that just by little things that you say to people, you can completely change their memories. So for example, she did a study where she had people watch a film of a red car crashing into a tree or something. And then she'd ask people the question afterwards, how fast was the blue car going when it crashed into the tree, even though the car was red? And then later she'd test people about their memory of the film, and people would remember, and they'd be 100% sure that it was a blue car that crashed into the tree, more from the question than what they actually saw. She's also done studies where she'd ask people questions about seeing the Flintstone characters at Disney World, for example, that kind of thing, and later test them about their memory of their experience at Disney World, and they would remember seeing the Flintstones there, even though they weren't there, just based on the question. She's done lots of research also on the whole, and I'm, by the way, just when she comes here, if she talks about this, it may not have been the Flintstones. I'm kind of changing the details of the story because I don't remember them. She's also done a lot of research on false memory syndrome, where therapists will induce memories of traumas, childhood sexual abuse in particular, in their patients. So the patients will say, well, I'm depressed. And the therapist will say, and they'll say, I've been depressed for my whole life since I was a kid. I don't know how it started. And the therapist will ask them questions. Well, are you having problems sleeping? And the person says yes, and they'll tick off, well, that's a symptom of post-traumatic stress. Maybe there was a trauma of some kind. The person will say, well, the therapist might suggest that the person was sexually abused, and the patient would say, well, I don't remember being sexually abused, and the therapist might tick off, memory loss, that's another symptom of post-traumatic stress disorder. And the therapist would start to believe that the person had this trauma, even though the patient had no memory of it, and then later it sort of came out there's no evidence for it. But over time, the patient came to believe it and started to develop these memories. So she's done lots of research showing how people's memories can be manipulated by these kinds of experiences. And another example that's coming to mind is Patty Hearst, who years ago was kidnapped and began over time to sympathize with her kidnappers. So people's experiences can lead to change, and whether they lead to this kind of change or not is another question. But those are a few examples anyway.
Yes?
Yeah, okay. So this may be a little flat, but I was noticing how when Jimmy Stewart was in the church, he took off his hat, which is social decorum, I guess, but also superstition. It could be. Is there a link between obsessiveness and superstition in just people in general?
There is a link certainly between anxiety and superstition. So people will do things, they will learn superstitious behaviors. So if they try something and they see that nothing bad, that maybe they wear a certain shirt and then they do really well on their exam, they may make a connection between the two and need to wear that shirt every time they take an exam. So we do see that kind of superstitious behavior in anxiety, and especially we see it a lot in obsessive compulsive disorder. So the whole idea, if you saw the movie with Jack Nicholson, As Good as It Gets, he was afraid to step on sidewalk cracks, and his fear was that is that he'd break his mother's back if he did that. So you do see that kind of superstitious behavior. Sometimes you see it in everybody, but especially in obsessive compulsive disorder. I just want to highlight that we're using the term obsessive to talk about Jimmy Stewart's character, and he was certainly obsessive in the colloquial sense, but not in the OCD sense. In OCD, obsessions are very much intrusive thoughts that people experience that they're afraid of. They try to suppress the thoughts. So it might be a thought of contamination. and then they have to wash their hands, or it might be a thought, an intrusive thought of hurting a loved one. They have to push that away because that's frightening to them. A thought about losing something, then they have to go and check over and over again. People with OCD, they don't like their obsessive thoughts. They find them frightening or distasteful or upsetting, and they need to suppress those thoughts. It's very different from the kind of obsessive quality that you see here more in the colloquial sense, where someone is just having this passion for something that they can't get rid of, this intense kind of rumination about something, almost the kind of thing that you might see in someone who's very passionate about their work, or in somebody who's a celebrity stalker or something like that. That's very different from OCD, even though we often use the word obsessive to talk about that.
Well, great questions. Thank you very much. It's a good thing they didn't make, version 2, 3, and 4 of movies in those days, because he would have a whole long list of psycho problems. I love that term, a good colloquial term. He went psycho. Who knows what he'd do next? Any ideas?
No.
Please give Marty Antony a good hand.
Great. Thank you very much.